Good afternoon, everyone. It's a great pleasure to welcome you all for this fourth session of the Icon Amrita E-Gurukul webinar series, mainly designed to benefit the DM and the DRNB medical oncology students. Today, our focus would be on drugs used in lung cancer, which is one of the most essential topics for the oncological trainees. To commence the proceedings, I have the honor to invite today's program director, and we do have a special distinguished panelist with us, Dr. Sendil Rajappa, who doesn't need any introduction. So before heading, I would invite our program director, Dr. Prashant Mehta. Sir is a great academic researcher and academician who's a senior consultant and program head, heading the Hematology and Medical Oncology Unit and BMT at Amrita Institute of Medical Sciences, Faridabad. Sir, handing over the sessions to you. Thank you.
Thank you so much, Gurukul team. So I'm not able to start my video somehow. The host has stopped it. Okay, no problem. I can request the host to allow me. Okay. So how are you all on this Sunday afternoon? We have very distinguished people here in this Gurukul, and this is pertaining lung cancer. And I think you can move the slide. So we have, I'll just introduce what this Gurukul is about. This is basically a continuation of the offline Gurukuls which we have had at Amrita, and we thought that maybe we switch to the online mode and we can run this program for the benefit of our fellows. And also, Karan has also taken great initiative in making this whole effort come true and realize it. And today we have completed the MPN Gurukul, and then there was CNS tumor Gurukul also last week. Probably I was not there that day, and now today we have lung cancer, and we continue this activity. Our course directors are Dr. MB Agarwal and Dr. Purvish Parikh, who have have been of have supported us immensely in taking this program forward, and we thank them. And today's activity is on lung cancer, and we hope that we'll have a great discussion today as well in this Gurukul. So I won't take much time, and continue with the program. The moderator for today on the screen you can see is Dr. Aditya Sarin. He's a good friend, and he's a very good academician, and always interested in knowing more and discussing. So he's there to moderate this whole discussion on lung cancer. I will hand it over to him. Aditya, please take it forward from here.
Yeah, uh, thank you so much, Dr. Prashant, for having me on this wonderful platform of Amrita E Gurukul and obviously drugs in lung malignancy in series 4. And 2 weeks back, I was having discussion with Dr. Prashant that let's take education and the discussion side by side, the involvement of our residents more into the programs, and we are happy that both the institutes, and it's going to be a multidisciplinary involvement. I think Dr. Prashant has such a great vision over here, because the backbone of any oncology institute are their students. If their students are trained well, I think they are supposed to go and do best for the community. And obviously the initiative is being lauded from pan India, and I must congratulate him on his wonderful success of this series. And without wasting further time, can I have the slide, and so that I can introduce my mentor? He's Dr. Akhil Kapoor, who's the professor, the Department of Medical Oncology, and he will be taking the discussions forward here. And we have Dr. speaker as Dr. Sabeena K. Choudhary, who's the consultant medical oncologist at Department of Thoracic Oncology at RGCI, New Delhi. And finally, I think one slide more is left. Yes. And my favorite examiner, he was there when I was doing my DNB. He's the co-director of medical oncology and chief of thoracic medical oncology at RGCI New Delhi, Dr. Ullas Batra. So I hope that the discussion goes as per time, and we all know lung cancer is increasing day by day. Last data set we have is of Globocon, and Globocon, you can just see there are to the tunes of approximately 1 lakh new cancer patients of lung cancer. And obviously, within the next 3-4 years, you are seeing more and more number. So yeah, I hand over the session to the speaker. And Examinee, obviously, they will introduce.
Am I audible?
Yes.
You're audible.
Yes, ma'am, you're audible. Ma'am, you can go to your slides, please.
Okay.
Yeah, if you can make it full screen.
Yeah.
Yes, ma'am, it's visible. You can go ahead, ma'am.
Okay. So first of all, I would like to thank the organizers for this wonderful opportunity. So not wasting much time, I'll start with my talk. So this is the 8th AGCC staging for lung cancer. And as first slide will be just the discussion on the brief outline for the treatment of lung cancer. Okay, so there is some disturbance.
Ma'am,
No, Sabeena, you are very well audible. Please go ahead. Maybe it's the overflowing of knowledge which is causing a disturbance for lesser mortals like us. Please go ahead.
Okay. So the first slide is basically on the treatment outline of lung cancer. So once the patient has been operated, we go for an adjuvant therapy for all stage 2 and stage 3, and for select high risk stage 1B, that is the patients having more than 4 centimeters tumors or an LVI or a high grade tumor. So for these tumors, we choose for giving adjuvant therapy in the form of a platinum based doublet, which is cisplatin or carboplatin. Obviously cisplatin is preferred over carboplatin, and it is followed by, depending on the driver mutation, if it is EGFR positive, after chemotherapy we give osimertinib for 3 years. If it is ALK positive, we give alectinib for 2 years. But if the patient is PDL1 positive and driver mutation negative, in that case we give an adjuvant therapy of atezolizumab or pembrolizumab depending on the PDL1 status. Now, also we have new adjuvant immunotherapy coming up in the form of nivolumab, wherein we give 4 cycles followed by surgery, and pembrolizumab, wherein we give 4 cycles of pembrolizumab with chemotherapy, then surgery, and then adjuvant pembrolizumab, and durvalumab. So these are the 3 drugs that we use as a new adjuvant strategy with significant EFS, PCR, and OS benefits. Now, if the patient is inoperable, that is having clinically evident N2 disease or N3 disease, in that case, we can go for CTRT followed by immunotherapy or osimertinib depending on the EGFR positivity. So, in concurrent chemotherapy regimens, we have paclitaxel or cisplatin etoposide. Then the major chunk of lung cancer that we see in our clinics is formed by the metastatic NSCLCs. And in that, treatment is driven by histology and the presence of driver mutation. So if the patient is not having any driver mutations, then we go by the PDL1 status, having less than 50% or more than 50%. If the patient has driver mutation, then we treat accordingly. So this is an organogram of our institute, wherein we saw around 26% EGFR mutations, 8% ALK mutations, 9% of KRAS mutations, 4% MET. So, starting with a case study, there's a 52-year-old female who is a non-smoker with a history of rheumatoid arthritis, currently in remission, presented with increasing dry cough, decreased appetite with weight loss of 2.5 months duration. On workup, workup revealed a mass of around 4 by 4 centimeter in the right upper lobe with bilateral lung nodules, with few liver lesions and skeletal mets. So basically, it was a metastatic disease with MRI brain was normal. And the tissue diagnosis revealed an SCLC adenocarcinoma with liquid biopsy having EGFR del 19 positive. So, how are we going to decide the treatment for this particular patient? So, as far as the NCCN guidelines are concerned, if the patient is having an EGFR exon 19 deletion or an exon 21 deletion, 8L858R mutation, in that case, the preferred strategy is EGFR TKI, which can be either osimertinib or any of the first or the second generation TKIs. And now even amivantamab with lazertinib combination is a category 1 as per the recent NCCN guidelines. However, uncommon mutations, we prefer afatinib or osimertinib. Uncommon mutations like S768I, L861Q, and so on. If there is an exon 20 insertion mutation, in that case, we go for amivantanab with carboplatin and pemetrexed-based chemotherapy. Or we can just go for systemic chemotherapy. So before we go on to EGFR proper, I would just like to tell you what is EGFR or what is ERB-B. So basically, ERB-B is a family of genes that are encoding for certain proteins which are known as receptor tyrosine kinases. Now, wherever the word kinase comes, that means somebody has to donate an ATP. Kinases is donating an ATP to the tyrosine because it is a receptor tyrosine kinase. So kinase is donating an ATP to the tyrosine. Once that tyrosine gets activated because of that ATP, there will be downstream signaling pathways and growth and differentiation of the cell. So basically, ERB family of genes comprises of ERB1, ERB2, ERB3, and ERB4. ERB1 is the EGFR, which is located on chromosome 7p. ERB2 is HER2, ERB3 is HER3, ERB4 is HER4. So the toxicities and mechanism of action of all these drugs will depend upon the targets of these molecules. So basically, how do TKIs work? As I told, tyrosine has to bind with an ATP to further work on with the cell signaling. So TKIs is tyrosine kinase inhibitor. So it is inhibiting the bonding of the ATP with the tyrosine residue. So once that is blocked, the phosphorylation will not happen. So if that is there, then cell signaling will be stopped. So in that way, we have the first generation, second generation, and the third generation TKI. The first generation TKIs were geftinib and erlotinib, with a PFS benefit when they combined with when they compared them with chemotherapy, the median PFS was 10 to 12 months, which was significantly better, but OS benefit was not there. And the main thing is that these drugs, the first generation drugs, they bind reversibly to the ATP binding site of the tyrosine. When we go down to the second one, so the main problem with the first generation was the development of resistance. So they tried to make something better than the first generation. So in second generation, they made some irreversible competitive inhibitors. So these, like afatinib or dacomatinib, they will form covalent bonding with that ATP binding site, and hence it will be more potent. The major side effect of the second generation which came up was that it was like a pan-HER inhibitor. As I told, it was ERB is a family of genes, so it will act on all these genes, like all the HER2, HER3, and HER4. So because of that, more severe side effects were there, like more of skin toxicity, more of GI toxicity. I'll talk further why these toxicities happen in EGFR TKIs. So afatinib and dacomatinib are, they basically pan HER inhibitors, and that is the reason they are better able to act on the uncommon mutations also. So third generation TKI was basically designed to specifically target the T790M mutation that came up with osimertinib. So osimertinib, as per the FLORA trial, it has a significant PFS benefit when it is combined with when it is compared with the first generation TKIs, and also an OS benefit. And also now another TKI is there in use, lazertinib. That is also a third generation TKI with better actions. So the patient on first generation or second generation, and even for third generation TKIs, they subsequently develop resistance to that. So why does that resistance happen? So when the patient is on first or second generation, they generally develop a resistance mechanism on the T790M mutation. There occurs a new mutation, that is T790M mutation at the kinase domain, that will cause EGFR to bind with ATP better than the drugs. So that mutation will cause more affinity of the EGFR to the ATP rather than binding to the drug. So this will be a mutation, a resistance mutation. Second resistance mechanism is a MET amplification or a HER2 amplification, any of the two. Then another one is C797S mutation. And then if a patient on first generation, second generation develops a T790M mutation, and you put the patient on osimertinib, on that the patient can develop a loss of T790M mutation, causing resistance to osimertinib also. And the another mutation that is there is not a mutation. Another histological transformation that can occur is small cell transformation. So that is also one of the reasons that instead of a liquid biopsy, we also do a tissue biopsy also, just to see the resistance mechanisms also, that what drug can be further used. So EGFR receptors are basically located on skin and the gut lining. So that explains the side effects of skin rashes, nail changes, skin peeling, dryness. And because of the gut lining, the side effects of mouth sores, oral ulcers that are very commonly seen with drugs like afatinib, and so diarrhea will be there. Then fatigue and decreased energy is generally a side effect of all the TKIs, so this is also there. Then increased liver enzymes, decreased platelet count, and decreased kidney function. So these are also the side effects. So these are like a class side effects which can be taken care of when you start a patient on a TKI, a EGFR TKI. You tell them to use a moisturizer or a topical or an oral antibiotic. If the patient has already developed rash, then you use some oral antibiotics depending on the severity of the rash. Then, for the mouth sores prevention, we should generally counsel the patient to do proper to take care of the proper oral hygienes and all. And also, if the patient develops diarrhea, depending on the grade, we will start proper prompt antidiarrheals so that it does not go on to grade 3 and grade 4. For fatigue and decreased energy, what all we can do is dose reduction. Again, for increased liver enzymes, what we do is frequent monitoring. So when the patient is started on the drug, we'll generally call them after 2 weeks with the liver functions and the CBCs. So the first
Ma'am, sorry to disturb you. Ma'am, on your screen, there is a pop-up which shows stop sharing and hide. Can you please hide it, ma'am?
Sorry?
Can you please click on hide?
Oh, one second.
Yeah, thank you, ma'am. Please go ahead.
So the first drug that was approved was gefitinib as per the IRSA trial. So gefitinib, it is used as 250 mg orally with or without food. It comes in the strength of 250 mg. And if the patient is having liver failure, especially CPC B or C, then we need to reduce the dose by 50%. There is no dose modification required for renal failure. So the common adverse effects, as I already mentioned, are skin reactions, which are 40 to 45%. Please note the percentages because in first generation, it will be comparatively lesser as compared to the second generation drugs. So 40 to 45%, rash, acne, dry skin. So once this happens, we need to withhold the drug for, if it is a grade 3 or a higher, we need to withhold the drug for 14 days, and then we resume it once it is resolved or it comes to grade 1. The another toxicity that we see is nausea, vomiting, and diarrhea. So GI side effects. Again, this is in the tune of 20 to 30%. And if it is grade 3 or higher, we withhold the drug for 14 days and then resume it once it is grade 1. The another side effect is proteinuria, LFTs monitoring that we do for AST, ALT elevations. So generally, if there is a grade 2 or higher ALT, so we classify the grading according to the CTCs. So if it is grade 2 or 3, grade 1 is generally AST, ALT is up to 3 times the upper limit of the normal. Grade 2 is 3 to 5 times the upper limit of normal. Grade 3 is 5 to 20, and grade 4 is more than 20. Similarly, for bilirubin also, we have this sort of a grading. Grade 1 is more than 1.5, the upper limit of the normal. Grade 2 is 1.5 to 3, and so on. So if it is grade 2 or higher, we need to withhold the drug for 14 days, and then we subsequently discontinue if it is very severe hepatic impairment, grade 3 or grade 4. Also, one of the known side effects is a GI perforation. So these are the warnings for that. So if it happens, we will not re-challenge the patient with the drug. Then keratitis is a side effect of almost all the TKIs. So we need to be very careful about the ocular symptoms. And then bullous and exfoliative. This is also like a warning. If the patient develops a bullous or exfoliative skin disorders, we need to withhold the drug for till it comes to normal. So the next drug is erlotinib. Erlotinib is also a first generation. And one thing I did not mention in gefitinib was ILD. ILD is also one of the side effects associated with all the TKIs with different frequencies. So we have to be very careful about ILDs. So erlotinib is used as 150 mg per day dosing, and this is to be taken on empty stomach, at least 1 hour prior to or 2 hours after food. And we need to, if there is any side effect, we need to reduce it in 50 mg decrements. That is, we have the dosage form and strength in the form of 25, 100, and 150. So if the patient is on 150 and we need to reduce the dose, we'll reduce it to 100 mg and subsequently to 75 mg, and wherein we can give 3 tablets of 25 mg. So again, the side effects are rashes, the skin side effects, rash, pruritus, paronychia. Paronychia in case of first generation, second generation is just 10 to 14%. When we go on to second generation, afatinib, it will be very significant. So GI side effects to the tune of 20 to 60%, it can be diarrhea. but 20 to 60% is generally grade 1 and 2. Higher grades are seen in very few percentages, that's 5%. Then musculoskeletal pain, myalgias can be there. Again, eye side effects, conjunctivitis, abnormal eyelash growth is a particular side effect for erlotinib. So the patient will have abnormal eyelash growths because of that, in entropion and all that can occur. Decreased lacrimation, dry eyes can occur. Then hepatotoxicity again is a major concern. ILD is a major concern. And also with erlotinib, we see myocardial infarction and ischemia. So we have to monitor the patient for regular echoes and all. Then comes a lot afatinib. So afatinib is almost like a pan HER inhibitor, EGFR. So it acts on exon 19, exon 21, and also on the wild type EGFR also it will act. So that is why causing more side effects. So if the patient is started usually on 40 mg orally, if the patient has a renal impairment, we reduce the dose to 30 mg. And again, this is also to be taken 1 hour before or 2 hours after a meal. So erlotinib and afatinib, they have relation with food, but geftinib you can give with or without food. Then this comes in strength of 20, 30, and 40. So dermatological side effects in case of afatinib because of pan-HER inhibition are more than 90%. And significant, we often see afatinib patients having skin peeling, blisters, and paronychia. It is very common with afatinib. And diarrhea also to the tune of 75 to 90%, 95%. So this we need to interrupt the therapy till it is less than equal to grade 1. And then we resume with a lesser dose, 10 mg lesser dose. If the patient is on 30, we need to reduce the dose to 20. And again, GI side effects like appetite, nausea, decreased appetite, nausea, vomiting, pruritus, stomatitis, all these will be the class side effects. Only the severity will differ. Again, as like in afatinib, dacomatinib. So these are very potent drugs. The second generation are actually very potent drugs because they are pan-HER inhibitors and they are very effective for uncommon mutations. Then we come to osimertinib. So osimertinib was, as I told, it was designed to be targeted for the T790M mutation. So it is a very highly selective drug. So that is the reason, despite being a third generation, the side effect profile is very good. So the side effects are very low. So see, as you can see in the dermatological, you can see the changes, discoloration, onycholysis, paronychia is all lesser as compared to the first generation, second generation TKIs. It is 25 to 35%. Overall rashes, 40 to 60% that we usually see, but they are usually manageable. Then another thing we see, lab abnormalities like hypomagnesemia, hypokalemia, LFT's derangement, and musculoskeletal pain. This is also quite common. And something that we see is ILD that is also there with osimertinib. And one thing that needs to be that is of concern is the cardiac toxicity with osimertinib. So any patient on osimertinib, we need to monitor the QTCs. So there is around 1.1% with the patients having more than 500 milliseconds as a QTC. So we need to regularly monitor the LVF by regular echo scans. And also a different toxicity is cutaneous vasculitis. So we need to evaluate for the systemic involvement and also consider the dermat consultations if you suspect something like rashes which are not typical of the normal rash and it looks like vasculitis. So this is the usual skin toxicities. In the week 1 and week 2, we usually see a rash, week 1 to week 4, rash with pruritus. And it can be an acneiform rash, something like that, as this patient is having. This was also one of our patients. And in the month 2, the other things start like stomatitis, mucositis, fissures, dry skin, trichomegaly. So that is all in the first month to second month. Nail changes will start around 6 to 8 weeks. And then later on, the patient will have, after 2 to 3 months, the patient will have alopecia. So how do you manage these things? Basically, the skin thing first and best is the prevention. So whenever the patient is started on osimertinib, we properly counsel the patient for using the topical emollients, topical steroids in case of it is topical steroids is basically a part of the treatment, not as a prevention. So topical emollients is what we tell them, and also we tell them for the effective sunscreens with an SPF of 30. If the patient is having grade 1, that is less than 10% of the BSA involved, in that case then we start with the topical antibiotics or a topical steroid. Grade 2 onwards, we start with oral antibiotics. Grade 2 is 10 to 30% of the BSA is involved. In that case, we start with oral antibiotics. And in grade 3 and grade 4, we need to hold the drug, or we need to reduce the doses of the drug. So in general, the rule of thumb is if the patient is having any grade 3 or grade 4 reaction, we withhold the drug for 3 weeks. And then once that is improved to grade 0 or 2, within 3 weeks, we start and we resume at either 40 or we resume at the same dose. But if there is no improvement within 3 weeks, we permanently discontinue the drug. And the major concern is QTC. This we need to be very careful. Like QTC interval greater than 500, on 2 separate occasions, we need to withhold osimertinib till it is less than 481 or recovery to the baseline. And we need to permanently discontinue if the patient is having signs and symptoms of arrhythmias or congestive cardiac failure. Another TKI is lazertinib. So this is basically used in combination with amivantamab for first-line treatment of adult patients with these mutations, as well as T790 mutations and double mutations. That is, patient having exon 19 with T790M or any double mutations. So this is a very good drug with amivantamab. So what are the side effects that we specifically see with lazertinib? Rashes, which is 85%, nail toxicity, infusion reactions. Then when you combine with the major thing, the main side effects will be the same as with other TKIs. But when you combine with amivantamab, then what we see majorly is the incidence of venous thromboembolic events is increased. So when you combine lazertinib with amivantamab, the major thing that we have to start is prophylactic anticoagulation for the first 4 months of therapy. So once anticoagulation treatment has been started, we can resume the drugs at the same dose. We do not need to reduce the drug. But if it recurs, then we need to permanently discontinue the drug, especially amivantamab, and we continue with only lazertinib. Another side effects that we see is ILD. That ILD will come in all TKIs. So the dose of lazertinib is 240 mg orally once daily, with or without food, in combination with amivantamab. And if it is given, so you generally give on the same day prior to amivantamab. So what is the mechanism of resistance of lazertinib? So this I told acts on T790M mutation also. So if there is a loss of T790M mutation, then the patient becomes resistant to lazertinib. Also, if there is a PIK3 downstream alteration, then also the patient will become, that is also a mechanism of resistance. And then C797 mutations. This is also one of the, and there are being trials going on C797 also. Then MET amplification is a major like mechanism of resistance for all TKIs, especially osimertinib and lazertinib. Then ERB2, KRAS, and BRAF. So all these will be the mechanism of resistance for these drugs. Then coming on to amivantamab. So amivantamab is not a TKI. It is a bispecific antibody which is directed towards the EGFR and a MET receptor. So basically, it is indicated for EGFR exon 20 mutations, either as first line or subsequent line. So the most common adverse effects that we see with the amivantamab are infusion related reactions. So whenever you start amivantamab for any patient, we need to first of all do it in an ICU setting, because at first infusion it is most common to get an infusion related reaction. Subsequently, the reactions will be lesser. Secondly, we have to pre-medicate with acetaminophen, with an H1 blocker, with steroids. So especially in the first week. And the other thing is, when you start for the first dose, we split the dose on day 1 and day 2 for the first cycle. Subsequently, we need to give on the same days. But for the first, we need to give on day 1 and day 2 of the week 1 with prior pre-medication and in an ICU setting preferably. So the most common side effects are again acneiform rash, ocular photosensitivity, ILDs, and infusion-related reactions. And the dosing also is different. When we combine with lazertinib or when we combine with chemotherapy, the dosing of amivantamab is different. And also it is weight-based. So less than 80 kg, the dosing is different. More than 80 kg, the dose is different. So as I told, if you can see, so week 1, day 1 and day 2, we split the dose. Suppose a patient is less than 80 kg and we're giving it with lazertinib or as a single agent, the dose is 1050. So half dose, less than half the dose, 350 mg, we give on the day 1 and 700 we give on day 2. And the initial infusion rate has to be kept very slow, around 50 ml per hour. Subsequently, we increase the rate. Week 2, we can increase the rate as well as we can give the full dose on the same day. So, and another difference in the dosing between when you give it with lazertinib or when you give it with the chemotherapy PEM carbo is when you give it with lazertinib, you give only from week 1 to week 5. You don't give the week 6. When you combine with the chemotherapy, then you do not give the week 5 also. So it is only week 1 to week 4. Week 5 and week 6 we do not give, and subsequently we start the infusion on week 7. So the infusion related reactions generally will be like the patient will have flushing, dyspnea, sudden onset dyspnea, fever, chills, nausea, chest discomfort, hypertension, vomiting. So this is very common after the first reaction, and then you grade the reaction. Then depending on that, we further manage. This is a typical skin reaction that one of our patients had with amivantamab. So this is before, and this is like during therapy. But the treatment was continued, and he was on in regular consultation with our dermatologist. So the patient is doing well, and manageable side effects. So now we come to ALK rearrangements. So ALK rearrangements, ALK generation, same. The drugs are first generation, second generation, and third generation. So mainly there are 5 drugs for ALK gene rearrangements. So the 3 generations. In the first generation, we have crizotinib. Second generation, ceritinib, alectinib, and brigatinib, which is not available in India. Third generation, it's lorlatinib. So all these drugs, they have different side effect profiles. So it is different from the EGFR TKIs, wherein they have class effects, almost similar side effects. In ALK, we have different side effect profiles, slightly different profiles. So why this happens is because suppose it is crizotinib. Crizotinib is working against ALK, also against MET and ROS. So it has off-target side effects also. So second generation ceritinib, it is active against ROS, IGFR 1 and 1R, IR. So similarly, so this is the reason they have different side effect profiles. For example, if we take crizotinib is mainly GI side effects, and then alectinib will have majorly myalgias. So these are the different. And brigatinib, it has a typical side effect of hypertension, and it has pulmonary symptoms. Very early in the start of the treatment, the patient will develop sudden shortness of breath, hypoxia, and chest tightness. So these are very different side effect profiles for all the drugs. So as we know, we choose the drug based on obviously the PFS and the OS benefit. So the best out of all those drugs is lorlatinib. So lorlatinib is one of the drugs with the best hazard ratio for both intracranial as well as extracranial among all the ALK TKIs that we have. So we choose also based on the side effect profile also, and also the financial constraints. So GI side effects are mainly seen with crizotinib and ceritinib. With ceritinib, they are more commonly seen. So ceritinib, I'll just discuss in further slide why GI side effects were seen more with ceritinib. So when it started, then pulmonary side effects more common with brigatinib. Grade 1 and 2 myalgias are more common with alectinib, crizotinib. Then hypercholesterolemia and hypertriglyceridemia. These are the major side effects for lorlatinib. So, and another benefit that we see with lorlatinib is the increased CNS penetration. Because of that, we see more CNS toxicity with lorlatinib. So coming on to crizotinib. So crizotinib, it was the first TKI which was approved against ALK. It was approved in 2011 by the Profile trial, wherein PFS benefit was seen 10.9 months versus 7 months. So it is also active against ROS1. So it is approved for ROS1 tumors also, first line. The dosage is 250 mg orally twice a day with or without food. And we need to modify the doses based on the renal impairment. So, and basically crizotinib, what the most common adverse reactions that we see with crizotinib are vision disorders. So vision disorders are very mild, although, so they are generally what happens when the patient wakes up from at night. So he's in dark. When the patient goes from dark to light environment, there are some visual trails which are left behind, and this is a very transient side effect which occurs like almost 30 seconds to 1 minute, and then it fades away. So for all these things, if you want the patient to take the drug for a longer time without hampering the efficacy by stopping the drug in between, we need to counsel the patients properly before we start the drug. The second thing that we see with the crizotinib is LFTs. So transaminitis is very common with the crizotinib. So before we start, we need to counsel the patient to come initially, like for the first 6 weeks, we need to call the patient every 2 weeks to monitor the LFTs, because the patient can develop a fatal hepatotoxicity in case these things are not monitored. So this is all about crizotinib. One major thing, if you have started the patient on crizotinib, we would like to call the patient for regular surveillance, especially because this does not have a CNS penetration. So if the patient is doing well clinically, the patient might develop some lesion in the brain. So we need to do surveillance for the brain also, because crizotinib does not penetrate the brain effectively. So if we are giving it for an ALK positive patient, we need to do monitoring for monitoring surveillance for brain scans also. So the second ALK TKI is Seritinib. So Seritinib, when it was started, when in the trials, the initial dose that was given was 750 mg, and that was like a fasting dose. So it had a very high emetic potential, and lot of GI side effects were there. But then in subsequently, they found out in many trials like Ascent 8, they found out if you reduce the dose to 450 and you give it with food, then it has some comparable good exposures as we see with 750 mg. So then they started using this regimen of 450 mg OD with food. So this is how the dose came down. Initially, GI side effects were very predominantly. So that was the reason patients used to discontinue. But now the GI side effects are there, but comparatively less as seen in the earlier trials. Another side effect that we see with Seritinib is again transaminitis, which is higher with Seritinib than other TKIs. So transaminitis, as compared to other ALK TKIs, it is higher with Seritinib. And then other side effects like fatigue, abdominal pain, weight loss have been reported in the trial. So that is also basically, we can say it doesn't. It is because of the predominant GI side effects that used to happen. So the patient's obviously food intake will be less, and then the patient will be having more of weight loss, fatigue, and abdominal pain. So all that was because of that. So now, if we give any patient a Seritinib, we need to give 450 mg OD with food. Then we come to alectinib. So alectinib is quite a tolerable drug. With, of course, it has GI side effects, AST, ALT elevation, ILDs as side effects. We need to monitor for that. But overall, it has a good tolerability profile. And the main side effect, which is different from other TKIs, as I discussed earlier, was severe myalgia. So in these patients, what we regularly do is we regularly monitor the patients with CPK, the muscle creatine phosphokinase. So in this, we do every 2 weeks for the first month of the treatment, and then if the patient is having any unexplained muscle pains or weakness or tiredness, then we go for subsequent CPK testings, and then we reduce the dose or withhold the drug depending upon the toxicity, CTC grading. And it comes as 150 mg strength, and the dose that we give is 600 mg twice daily, and we administer alectinib with food. And the other side effects are edema, fatigue, constipation, anemia, apart from myalgia. Then coming on to lorlatinib. So lorlatinib is also now, as I told, it is the drug with the best hazard ratio among all ALK TKIs, with good intracranial and extracranial response rates. So the unique side effect of lorlatinib is hypercholesterolemia, hypertriglyceridemia, which is not seen in other TKIs. So, and other side effects like peripheral edema. Peripheral edema, the patient will have weight gain, they can have pedal edema. So, peripheral neuropathy. The another side effect that is different is cognitive effects, because it has a better CNS penetration. So, side effects will be more with in that. So, the things that we tell the patient before we start lorlatinib is weight monitoring. At the baseline, we send the samples for lipid profile and all, and if anything is deranged, we try to correct them. During treatment, if it is there, hypertriglyceridemia or hypercholesterolemia, we tend to start with fibrates or rosuvastatin statins. And we need to counsel the patients prior to the start of the drug for the weight monitoring. And also, another thing that we have to tell the patient is to keep a check on the behavior changes and the attendants also. We usually tell the attendants of the patient also that the patient will have some mood swings, will have anger issues. So these things are there that happen with lorlatinib. The first thing when the patient comes on follow-up is we generally ask for any mood disturbances, any anger issues, any weight gain. So these are the things that we look for. And generally the dose that we start with is 100 mg OD with or without food. So again, there is a risk of serious hepatotoxicity, especially if we give it the CYP inducers. Then CNS side effects like seizures, hallucinations, and changes. So for dose modification regarding the CNS side effects, if it is grade 1, that is just mild, we tend to continue with the same dose. Or grade 2 and grade 3, we withhold the drug till it is grade 1, and then we re-challenge either at the same dose or we re-challenge with a one dose lower level. Like we start with 75 mg, and then we subsequently increase. If it is grade 4, although the recommendation is we do not re-challenge the drug, but then again that is case to case basis. So we can re-challenge at a lower dose if the patient is doing clinically very well and the disease is well controlled. Then in that case we can go for maybe reducing the dose to a very low level and then subsequently increase the dosing later. The next is KRAS mutation. So the next in line is KRAS. So KRAS, it is KRAS 12 G12C mutation. And in this, first line therapy is not KRAS inhibitors. Generally, after prior treatment lines, we start with the KRAS inhibitors. So sotatercept and adagrasib, these are the two KRAS inhibitors that we have that we give on subsequent progression. So before starting KRAS inhibitor, we need to check the PDL1 levels to determine the first line therapy. And these are recommended as subsequent therapy options for patients who have progressive disease after first line therapy. And we can also use them as third line. So if the patient progresses on one agent, this is not recommended to start the other agent. So because both of them have almost similar efficacy, and so there is no point of changing the drug. It is not recommended. So sotatercept is 960 mg OD that we give. The most common side effects that have been seen in the code-break study were pain, abdomen, and altered bowel habits. So predominantly the GI side effects. So both of them have the similar side effects, GI side effects and fatigue, and also raised myalgia. So these patients should also be monitored by CPK levels. And edema is also a significant side effect. Skin subcutaneous thickening. For adagrasib, we use a dose of 600 mg BD. Then coming on to the MET exon skipping mutation. So either there are three types of variants that we see in MET. Either it is a MET exon 14 skipping mutation, or it is a fusion, or it is an amplification. So generally we see MET exon mutations in primary cancers, and most commonly it is seen in those where histologies are sarcomatoid variants. So if a patient of NSCLC is having adenocarcinoma with sarcomatoid variants, we need to definitely look for MET exon skipping mutation, because these are more commonly seen in sarcomatoid variants. Then MET amplifications are more commonly seen as a resistance mechanism to EGFR TKIs, as a secondary resistance mutation. And overall, MET mutations are mutations or amplifications are most common in older patients.
अभी इसके बाद क्या?
So most common in older patients, and the incidence is equal in males and females, and there is no relation with smoking. And PDL1 expression is very common in patients having MET mutations. So there are three drugs basically. One is crizotinib with an overall response rate of just 10%, because this is also one of the targets for crizotinib. Then capmatinib, which in the geometry study there was a median PFS of around 12.5 months, with an overall response rate of 68% when used as a first line. So when it is used as a second line, the response rates were still good, 40%. First line, even better, 68%. Tepotinib was studied in the vision study, wherein overall response rates were in the first line 58.6, almost similar like capmatinib. In the second line, when tepotinib was used, it was 50%. So slightly better, we can say, as compared to capmatinib, although direct comparisons are not there. So both the drugs can be used and they are both equally good. So capmatinib and tepotinib can be used as first line for MET mutations, as well as amplifications. And if both the drugs cannot be used, then we go for crizotinib. So this is one of our patients who was a 61-year-old male patient. He had presented with right-sided chest pain and dry cough of 1 month duration. So it was basically a metastatic disease as per the PET. There was no lesion in the baseline MRI brain, and the biopsy came as adenocarcinoma of the lung. He was started on PEM carbo. So this is usually what we do is we initially start all the patients on chemotherapy. By 3 weeks or so, our NGS report comes, and then based on that, we decide whether we have to give a PDL1 inhibitor or we have to give a driver mutation drug. So for this also, we started him on PEM carbo initially, and the report came as NGS report came by that time 14 exon 14 skipping mutation in the MET. So we started the patient on capmatinib in January 2022. So later the patient had an interval development of one single brain lesion, and there was a PR in the extracranial sites. So in this case, we continued with capmatinib and we gave SRS to the brain in September 22. So the only adverse effects that was seen during this time was a generalized swelling over the body. In this picture, this is not that clear, but the patient is still having skin thickening over the both the feet and the hands, but it is not troublesome for the patient. So this was there's general, and there was a weight gain of around 81 sorry weight loss 81 kg in May 22 to 79 kg in August 22. So SRS was done and the patient was kept on capmatinib. Then by the next year, the patient had another PD. Again, that was also in the cranial side. At the extracranial side, there was stable disease. So we again took the decision of keeping the patient on capmatinib, and we gave whole brain RT to the brain. Finally, 1 year later, now the patient developed both cranial as well as extracranial PD. And in NGS, there is no further mutation. So now we have started the patient on pembrolizumab, PEM, and carbo. So currently the patient is on pembro and PEM maintenance. So this is highlighting the good PFS that we see with the capmatinib and tepomatinib, and good response rates also. So the dose that we use as per the geometry trial is 400 mg twice daily with or without food. And the most common adverse effects that we see, the one that I showed was skin and subcutaneous thickening. Then again, rash, decreased appetite, and another side effect that is of concern is increased serum creatinine. So we need to regularly monitor the patients for serum creatinine. And also, because they have a good CNS penetration, dizziness is also a side effect. And the warning and precautions that we need to know are, if the patient is having severe abdominal pain, and then we need to monitor for amylase lipase also if the patient is on capmatinib, and of course severe hepatotoxicity, so the patient has to be monitored for regular transaminases. And ILD, as I told, is for all the so any patient on any TKI, if they are having any sudden new onset of cough or shortness of breath, we need to rule out other causes, all the causes of this, like infective causes, and ILD should be kept in mind before sending the patient home. So the next is RET gene rearrangement. So this is seen in around 1 to 2% of the patients. So the drugs that we have for RET gene rearrangement are cabozantinib, selpercatinib, and pralsetinib. So cabozantinib is a multi-kinase inhibitor. It is used in this also. So selpercatinib, as it came out in the Libretto trial, it even in the second line when we use, there is a significant good overall response rate of around 60%. So good responses are seen with selpercatinib. And responses are seen within 2 months. So that is what was seen in the trial. So once you start the patient on selpercatinib, you can start seeing the responses within 2 months, because that is usually in the clinical trials we do scans very often. So they have reported within 2 months the patients had a documented response. So, and as first line, even higher overall response rate is seen, that is around 80%. And the best part is the responses are quite durable. And also intracranial response rates around 80% is there. So not only intracranial response rates, it also prevents the development of further brain metastasis. So the major side effects of selpercatinib and pralsetinib are all because of the off-target toxicity. So off-target toxicity will be in the form of GI side effects, nausea, vomiting, diarrhea, edema, dryness of the mouth, fatigue, LFTs, QTC prolongation. There is one side effect which occurs because of the RET in close proximity to VEGF. Because of the blockage of VEGF, the patients can have hypertension. So any patient we start on pralsetinib or selpercatinib, BP has to be monitored regularly. Now, there are certain side effects which are unique for sulfacatinib, that is hypersensitivity. So this was quite of concern. So if the patient started on sulfacatinib develops a fever, rash, joint pain, and if it is quite severe, hypotension can occur, low platelet count can occur. So that is a hypersensitivity reaction. We need to monitor it promptly. We need to address it promptly. And these side effects were majorly seen in patients who have received prior immunotherapy. So, if the patient has received prior immunotherapy, we have to be very careful before starting sulfacatinib. We need to pre-medicate before starting sulfacatinib. And the other unique side effect that we see for sulfacatinib is chylous pleural effusion. So, in the trials, it was seen like the pleural effusion was increasing. It was not because of the disease progression; it was a chylous pleural effusion, which can easily be managed by low fat diet and.
Dr. Sabeena,
Yes, sir.
I think you need to look at the time as well, because the next Viva and examining video that needs to happen. So
So I am
uh,
just covering the
two, three
TKI,
more
sir.
minutes.
Okay, we'll be done. Then I'll be a bit fast then. Okay. So sulfacatinib and pralsetinib. Pralsetinib, the major different side effect for pralsetinib is a hematological toxicity and hypertension. That is because of VEGF. So this is sulfacatinib I discussed in the previous slide. Then coming on to ROS, so we basically have crizotinib, entrectinib, repotrectinib, and lorlatinib for as the ROS inhibitors, and there was a okay, entrec gene fusion, entrectinib, larotrectinib, and repotrectinib. So, repotrectinib, the major side effects that we see with the ROS and NTRK inhibitors are CNS side effects. So, dizziness, dysgeusia, taste changes. So, GI side effects and CNS side effects. These are the major side effects that we see with repotrectinib. And again, as in other serotonin type TKI, we need to monitor for myalgia, CPK elevation. So then is the BRAF inhibitor. So the one point I would like to tell is we use dabrafenib not alone. We use with a MEK inhibitor. Whenever we are giving a BRAF inhibitor, we should combine it with with a MEK inhibitor. That is to increase the efficacy. Second, to reduce the side effects, skin side effects. So these are the two main reasons that we combine with dabrafenib and trametinib or encorafenib and vemurafenib. So the major side effect that we see for combination of BRAF inhibitors and MEK inhibitors is a fever, dermatological side effects, and cardiomyopathy. So pyrexia is a very important side effect of combination therapy with dabrafenib and trametinib, and we need to monitor as per the CTC grading. Then trametinib is a MEK inhibitor that we combine with BRAF inhibitors to increase the efficacy and reducing the side effects. So this was one of our patients who had developed an intestinal perforation with trametinib once we started. And this is also a major, I mean, it is not mentioned as such in the high percentage, but it is still there. So we need to look out for all these things. And entrectinib and larotrectinib. So the basic difference between the toxicity of entrectinib and larotrectinib is with larotrectinib, we see more of dizziness and LFT abnormalities. With entrectinib, we see more of taste changes and GI side effects. Rest, most of the things are same with entrectinib and larotrectinib. So this is one of our patients who had developed perforation on entrectinib. So that's, and if you see, these are the side effects with this, and this is just sorry. The cursor has gone down. The large intestinal perforation, if you see, it is only to the tune of 0.3%. So 0.3% means it can happen with our patient also. So we have to be very careful with the side effects. And HER2 mutations is trastuzumab deruxtecan, that is TDXT. And the major side effect of concern, major concern is ILD, bone marrow suppression, GI side effects. So major is pulmonary toxicity that we see with TDXT. We have to be very careful. So last few slides, drug-induced ILD, we need to be careful about any new onset cough, dyspnea, low-grade fever, or hypoxemia. The risk factors for drug-induced ILD are comorbidities, patient being a smoker, active or previous smoker, history of lung disease, compromised lung disease, or prior history of RT to the chest, and the dose of the drug in question. So early detection is the key. Whenever patient on TKIs with significant if ILDs percentages, we need to perform a baseline PFT DLCO plus minus HRCT to see how the lungs are. And at every visit, we need to be performing a 6-minute walk test even if there are no symptoms. So this will considerably help us detecting an ILD earlier, drug-induced ILD earlier. And how do you manage? We first rule out all other causes, and at first suspicion, we should start with steroids, and then later, if it is proved, then we start with high-dose steroids depending on the grading of the ILD. So pemetrexed, it is an antifolate drug. I'm sorry, I have to rush through the slides. It is an antifolate drugs, and the main thing that we need to address with pemetrexed is all the patients should receive vitamin B12 IM injections every 3 cycles, that is every 9 weeks, to reduce the risk and toxicity of the drug. And also they should receive vitamin folic acid and 350 mg per day. The dose should not be very high because there are reports of reducing the drug efficacy if you increase the folic acid too much. So 350 mg per day. So if you have a 5 mg drug, you need to give it on alternate days, something like that. And this drug is not very effective for squamous cell carcinomas because the enzyme that it inhibits, that is thymidine synthase, that is expressed in high concentration than the squamous cell carcinoma. So it is like a resistance mechanism. It will not respond to pemetrexed. And we need to use prophylactically steroids for pemetrexed. It is not to reduce the nausea, vomiting. It is to reduce the incidence of side effects, skin rashes. So the difference between Dexona in pemetrexed and other drugs is this. And if you do serum homocysteine level for these patients, it can be a good predictor for development of grade 3, grade 4 toxicities that we see with pemetrexed. Some patients, very few patients, can develop a pancytopenia. For those patients, I think if we do a baseline monitoring for serum homocysteine level, that is an indicator of reduced folate in the patients. And the dose that we use is 500 mg per meter square IV every 3 weeks. The adverse effects for pemetrexed, we all know, is myelosuppression, skin rash, hand-foot syndrome. Thank you. So the immunotherapy will be covered the next other topics.
So obviously, you have extensively covered most of the targetable drugs, and we are seeing how only target therapy, majority of the bulk and the innovation is being done in lung cancer itself. And
Yes.
obviously, I will not be standing in between you and Dr. Ullas Batra. So I think over to you, Dr. Ullas. I think for the Viva, and we have Dr. Chakradhar as well. So I think over to you guys.
Okay, fantastic, Sabeena. Great talk. I am so happy that you are the one who is taking this talk, and I'm so happy that I am not the one who is answering this Viva. Okay, great. So, Dr. Chakradhar, let's say somebody you know has been diagnosed with stage 4 lung cancer. This is out of the box, Sabeena. So,
Okay.
what mutation or what would you want the patient to have? I mean, obviously, nobody should have this problem. But what mutation or what do you want the patient to have a PDL1 of 90% or an ALK or an EGFR or RET? Money is not an issue.
EGFR, sir.
EGFR. And your reason why for that, Dr. Chakradhar?
The osmanthib can be better outcomes, and progression-free survival is about, and it is with single drug we can have less side effects.
Fantastic. So what is the PFS with the osimertinib, Dr. Chakradhar?
19.4 months.
Fantastic. And what is it with lorlatinib, Dr. Chakradhar? I gave you all the options. Patient can have a PDL1 of 90%, patient can have a PDL1 of 0%, patient can have EGF or ALK, whatever. Okay. So with lorlatinib, I think Dr. Sabeena did show that with the Crown trial at 5 years, 65% have not really progressed on that. Patients are now expected to have a median OS of around even more than 7 to 8 years. And the other benefit of immunotherapy could have been, I mean, EGFR was a fab thing in the retro times to come. But right now, I think a PDL1 of 90% where you have a limited duration of treatment and 5 year survival of maybe 30%, 40% with only 2 years of treatment could have been there. No worries. So Dr. Chakradhar, if you give a patient osimertinib, what do you tell them? How do you follow up the patient, and what are the basic investigations that you do?
Basic ECG, sir, to look out for QT prolongations or anything.
So one is ECG you will do. You will do a QTC interval. What is the formula that you use for QTC, Dr. Chakradhar, or you just look at the top of that?
Actually, we use that
Very good.
apps. Actually, we use app by calculating Q interval distance with.
So let us say the QTC is 485. What will you do? Okay. So QTC is found using the Bassett's formula. Please, all the residents, don't even only look at the top strip of what is written in on the ECG. It can actually miscalculate. It's the Bassett's formula, and you should all have a look at that. Any other drug which causes QTC interval prolongation, Dr. Chakradhar? May not be in lung, some other drug?
ATO, sir.
Come again?
APML, sir. In APML,
APML. Very good. Very good. Very nice. Fantastic. So you will do an ECG. What other than this thing, and what do you tell the patient when you start the patient on osimertinib regarding the toxicities?
Sir, if any increasing in the shortness of breath, we should initially inform, sir.
Okay.
And hyperglycemia, sir, and any weakness like any seizures, like look for serum after the starting of osmanthib, we look for the serum electrolytes, sir.
Serum?
Electrolytes, sir.
Electrolytes. Very good.
And target like lesions, any skin lesions like target like lesions, we should check, sir.
So let us say you have a 40-year-old man or a woman who has an outside job, who works in who has a, let's say, sales or marketing job, and the patient is very much bothered about the skin toxicity. So they want osimertinib, they don't want second generation TKI. What things will you ask the patient to? What will you ask them to do? What will you ask them not to do? Let's say they are going, I mean, so she is very bothered. This is a female. She's very much bothered about her skin toxicity, about her other things. So what are the things that you will tell to prevent this, to reduce the risk?
We'll ask them to cover less skin sun exposure, sir.
You will ask them to cover the skin. Okay, let's say they are living in Delhi. So one is you have to avoid, they can wear a hat or something. They can wear a top. They can wear a cap. They have to avoid high skin. One. Anything else that you will ask them to do?
Sunscreen application of sunscreen, sir.
Very good. Very good. You have to have a sunscreen application with the index more than 15. Very good. And let's say she gets so how do you classify the skin rashes?
Based on the body surface area, sir. If the
Okay.
it is more than 10%, sorry. If they are based on body surface area, sir, if the grade 1 is less than 10%, sir, grade 2 is more than 10%, and grade 3 is 10 to 30%, sir.
Very good. So one, we spoke about skin rashes. I mean, so why is it so skin rashes are most highest with grade with the generation 1, generation 2, or generation 3 toxicities, toxicity drug? It is most highest with which drug?
With first generation, sir.
With first generation. Okay. So let us say you have started the patient on, tell me the second generation TKI, Dr. Chakradhar.
Dacometinib and afatinib, sir.
Very good. So what is the dose of dacometinib?
180 mg, sir.
180.
First initially start with 90 mg for 180.
I think you got confused with brigatinib and dacometinib. Dacometinib dose is 45.
45 mg, sorry, sir.
It doesn't make a difference. It is not a very commonly used drug, so absolutely okay. So let us say somebody is getting a very high toxicity with dacometinib of 45 mg or afatinib of, what is the dose of afatinib, Dr. Chakradhar?
40 mg OD, sir.
Fantastic. So let's say somebody is getting a toxicity. Let's say a grade 3 toxicity. How will you manage that?
If there is a grade 3 toxicity, we withhold the drug for initially. We should ask them to withhold the drug, sir, and we'll ask them to with grade 3, we'll allow oral antibiotic with doxycycline or minocycline, sir, 100 mg BD for 7 to 14 days, and if they require topical antibiotic with topical hydrocortisone, sir, steroid.
Hydrocortisone, and then you will restart at when?
After 14 days. 14 days.
After 7 to 14 days, whenever the toxicity comes on. Very good. What is the dose that you will start, Dr. Chakradhar?
30 mg, sir.
30 mg. So you can, and the patient will ask you whether when I'm reducing the dose, will my efficacy of the drug come down?
No, sir.
It won't. And we have a trial to show that?
Sorry, sir, I doesn't remember the name.
Yeah. So in the Archer trial and in the Lux trial, they have shown that people who reduce the dose from 45 to 30 or from 40 to 30, they did not have any problem. So there's a lot of tendencies for all the medical oncologists to keep on giving them. 30 mg might be a fantastic dose actually. No worries about that. Okay. Let's just forget the EGFR toxicities. Let's just go on to lung to ALK toxicity, ALK region. So let us say you have a patient, a 35-year-old female who's who's a professor or a doctor. She's a ENT surgeon, and she has been diagnosed with stage 4 ALK rearranged non-small cell lung cancer. The disease sites of diseases are in lung, right lung mass, some pleural effusion, adrenal, liver, bone, and brain. She is asymptomatic for the brain metastasis. ALK fusion is positive. It's a variant 1. What is your choice of regimen? Money is not an issue right now.
We'll go for lorlatinib, sir.
You will go for lorlatinib. Fantastic. Why lorlatinib and why not a second generation TKI or a first generation TKI?
Because lorlatinib has better blood-brain barrier penetration, sir. So
lorlatinib. Very good. So very nice. So let us say this patient did not have brain mets.
Sir, if the patient is affordable, we can go with lorlatinib, sir, or we can go with second generation also, sir, with alectinib or brigatinib also, sir.
And what is the dose of alectinib?
Alectinib is 600 mg BD, sir.
Very good. To be taken with food or without food?
Without food only, sir. If high fat diet, it increases the absorption. So
that I think is with seratinib. So what is the dose of seratinib, Dr. Chakradhar?
750 mg OD, sir.
With food, without food?
1 hour before food, sir, without.
Okay. So you're right. The dose of seratinib is 150 mg, 5 tablets if you're taken without food. But there was a trial in which they found out that 750 mg was compared with 450 mg when it was supposed to be taken with food. And 450 mg per day was absolutely okay with that. So let's say, Dr. Chakradhar, we agreed with you and we are going to give lorlatinib. What is the dose of lorlatinib?
100 mg BD. Sorry, OD, sir.
100 mg OD. Fantastic. How will you monitor a patient on lorlatinib?
Initially, we should do baseline fasting lipid profile, sir.
Very good.
Weight, we should check for weight also, sir. And for weight and ECG also, sir, we should do. And we should repeat after every cycle to check for any weight gain or increase in the triglyceride levels or cholesterol levels or any visual hallucinations, cognitive disorders. We should check for every cycle, sir.
Okay, so let us say the patient has started on lorlatinib and the patient's cholesterol has now increased to 350, triglycerides are 450 on day 15. What will you do?
We should start on statins and phenofibrates, sir.
You will start with phenofibrate to begin with.
Sir?
You will start directly with phenofibrate or there is something else that you would like to start with?
Statin, sir. Initially, we'll start with statins.
Which statin will you give? The patient was already taking atorvastatin. Rosuvastatin. The patient has already been taking atorvastatin. Is it okay to continue with atorvastatin or you would specifically want rosuvastatin? Okay. So atorvastatin is not supposed to be given with the lorlatinib. You will all find out the reason why today. It is rosuvastatin you will give. What is the dose of rosuvastatin, Dr. Chakradhar?
20 mg.
You will start with 20 mg?
Yes.
Okay. You normally start with 10 mg and then you will increase the dose to 20 mg. And then if it still doesn't come down, you have to decrease the dose. You have to add phenofibrates, which is fantastic. One more side effect. So how frequently do you call the patient on lorlatinib? To your OPD?
15 days.
Once in 15 days, is it?
Yes, sir.
And what is one major side effect? Let us say patient's wife comes and tell you or patient's spouse comes and tell you that, patient has become very aggressive.
Yes, sir.
He is getting irritable, angry, he's throwing things here and there. Then what will you do?
It's an impulsive control disorder, sir. We ask them to initially we'll hold the drug and if see dose reduction can be done, sir.
How much?
25 mg, sir. We shall give for 75.
So absolutely right. But what is the strength of lorlatinib that it comes usually in? So lorlatinib comes in two strengths. One is 100 mg and one is 25 mg. You should actually, first of all, hold the drug. You should stop the drug. And you should always, first of all, counsel the patient prior that, don't, if you get any untoward symptom like this, like any mood swings, anger, irritability, very few people have got suicidal tendencies, but less than 2% of people can get a grade 3, grade 4 event like this. Immediately stop the lorlatinib drug. The half-life of lorlatinib would be, Dr. Chakradhar?
Sorry, sir. I think around 30 hours.
So it's by and large in some hours. So the moment you stop this drug, within 2-3 days, the things will get down. Consult a psychologist, consult a neurologist, and then restart at a lower dose of 75 milligram, which is great. So let's say, Dr. Chakradhar, that a new patient comes of non-small cell lung cancer, stage 4. PDL1 is 90%. EGFR ALK is EGFR is wild type, ALK is non-rearranged. How will you stage 4 without brain mets? How will you manage this patient?
If the patient is young and based on PS and
PS is 0.
PS 0 and no symptomatic, we can start with single agent pembrolizumab, sir.
Very good.
If the PS is good and patient is having symptomatic, we can start with pembrolizumab with chemotherapy, sir.
Fantastic. So you gave the patient a single agent pembrolizumab, which will be at a dose of
200 mg 2 weekly, sir, or 400 mg.
Okay, the dose of pembrolizumab is 200 mg once in 3 weeks, which is absolutely all right. Will you send? I said it. We have EGFR and ALK is negative. Do you send for an NGS for everyone?
If the
patient was a non-smoker, I did say that.
You
will send the NGS. Fantastic. After you have given first dose of pembrolizumab, the report comes as ROS alteration positive. Now what will you do? ROS fusion positive. So patient came to you on January 1. The report came to you on January 5th. You gave the next dose on January 5th itself of pembrolizumab. Now on January 27th, patient has come to you with a report of ROS1 fusion positive. What would you do?
We'll continue pembrolizumab, sir.
You will?
We'll continue, sir.
You will continue with pembrolizumab. Okay. Anybody else has a different view? We can just type the question over here. So here I will disagree with you, Dr. Chakradhar. Actually, pembrolizumab doesn't really work in a biomarker-associated lung cancer. There were two messages I wanted to convey with this. Nobody should start a immunotherapy single agent or in combination without ideally getting a full panel NGS12 gene report. That is number one. And the second thing is, if you have started pembrolizumab, don't be in a hurry to start oral TKIs because the half-life of pembrolizumab is high. And if you give pembrolizumab and followed by either capmatinib or osimertinib or something, there's a very high chance of a drug-induced pneumonitis. So please keep a 3-month window at least between a TKI and a immunotherapy. So that is a learning point for all of us, and we have all burnt our fingers in this. So first of all, do not start a patient on TKIs. Do not start a patient on immunotherapy if you till the time you have an NGS report. Secondly, if you have started it, keep a 3-month gap and tell the patient there could be a ILD, there could be a drug-induced pneumonitis. Come back if you have something of that sort. Fantastic. So let's say this patient was not started on anything and ROS came positive. What is the drug that you will give?
Crizotinib 250 mg BD.
Crizotinib 250 mg BD. Fantastic. Patient also has brain mets. So do you like to? So does crizotinib cross the blood-brain barrier?
No.
Aditya, please let me know how much time do I have? I will keep on going. Hello.
Sir.
Yeah, Aditya, please let me know how much time do you have, and you can post in the chat box, and I will stop at that time. So there was a question that okay. So why does crizotinib not work in brain mets, Dr. Chakradhar? Why is it that crizotinib does not work and lorlatinib works?
Because penetration of the blood-brain barrier is less compared to lorlatinib. Crizotinib is have less.
Why is it less? That's what I'm asking you. We all understand that it doesn't cross the blood-brain barrier. Why? So why does generation 1 TKIs, let us say a gefitinib, does not have that much of a great brain activity, and why does osimertinib have more? And why does similar for crizotinib and lorlatinib? I think all of you should go back and find out about the drug efflux system, the P440, 450, how does it act? I think all of you should go back and read that today. Okay. Let's say the patient has, there are a lot of questions here regarding there was one question by Dr. Vivek about, so let us say, Dr. Chakradhar, I'll ask this question to you only. Lorlatinib you have given, and then the patient basically has a cholesterol level of 350 and 450, as I said. So will you reduce the dose of lorlatinib, or will you add rosuvastatin first and continue the same dose of this?
So we'll initially start with rosuvastatin will add, and that will continue same dose. Sir. If there is no response, then we can go for decrease in of the dose for the lorlatinib.
Okay, so you should start with the rosuvastatin, add fenofibrate, and then only consider decreasing the dose of lorlatinib. So you should add rosuvas first. Dr. Sabeena, you had certain questions.
Disham, can you go ahead with the slides?
Time, sir. You are there till 3:30 only, no?
I don't know what is the time limit. Initially, I was told 20 minutes, and now I have been told that they have some more
I think
time.
we don't have time left for the for those questions. You have
You can just show some couple of questions. We can just go for that.
Okay, sir.
So can the Dr. Aditya, how much time is there for this particular thing?
So sorry to interrupt, Dr. Aditya is left for the
It
session.
doesn't make a difference. So
sir,
how much? Yes.
We have 40 minutes more, sir, including the question answers, which has been posted in the chat box also to be discussed.
Okay, so let's just start. I think Sabeena had certain questions. We can do Sabeena's question, and then we can answer the chat box questions. So yes, Sabeena, please go ahead.
So a patient on first-line EGFR TKIs developed PD after 7 months. T790M mutation was negative on liquid biopsy. So what is the next step in the management? Am I audible?
Yes, ma'am. Hello. Hello.
Yes, Dr. Chakradhar, you can answer to Dr. Sabeena's questions.
Yes, ma'am. We based on the we can start with the third generation TKS, ma'am. Second generation, because T790 mutation was negative. Hello.
Okay. First generation, the patient has progressed and T790M is negative. What is the next step? Do you go for a tissue biopsy in this case?
Yes, ma'am. We'll go for tissue biopsy also.
Ullas?
So you have under the patient has got PD after 7 months. T790M is and negative on liquid biopsy. So first of all, we should know what is liquid biopsy. So what liquid biopsy will you do, Dr. Chakradhar? Let us say on the form, what will you write? So you will just write liquid biopsy, or you will write, I mean, whether we will do a single gene testing, double gene, I mean, NGS panel, or what would you write on the form?
Doesn't have ideas because I have.
So this is for everybody. When you write liquid biopsy, liquid biopsy is a very huge term. It's almost like saying, we are doing oncology. Oncology has so many different things. Oncology, hematology. So if you are doing a single gene testing, you will write either for a COBAS test by PCR, or you will ask for a DDPCR. There's a digital droplet PCR. That is what is uniquely normally done, because the report will come in 5 days time. A liquid biopsy NGS panel can have a lot of panel, which will include EGFR, ALK, and everything. So first of all, the most common test which is normally done is a single gene RT-PCR testing to look at T790M, this thing, which either by COBAS or by droplet digital PCR. So this has come on negative. You would like to do a tissue biopsy. That's what you said, Dr. Chakradhar?
Yes, sir.
Why would you like to get a tissue biopsy?
Sometimes tissue biopsy have the.
So let us say a liquid biopsy comes as T790M negative and tissue biopsy comes as T790M positive.
So we'll consider as a mutation and we'll go for a third osmatin.
Fantastic. Now let us say tissue biopsy comes as negative and liquid biopsy comes as positive.
So we'll consider as we'll go for a osmatin also.
Fantastic. One reason why we should always do, I totally agree with Dr. Chakradhar, one reason why we should always do a tissue biopsy is to rule out a small cell transformation. Have you seen that, Dr. Chakradhar?
No, sir. No,
okay. So normally, if you do a tissue biopsy routinely on that, there's a 5 to 7% chance that you will get a small cell transformation. Please always you should go ahead and do this thing. Now let us say the patient has come as negative for T790M on both tissue and liquid, but the patient does not want a oral TKIs. A patient doesn't want a chemotherapy. So what is the PFS if in a T790M negative patients you put the patient onto osimertinib?
Around 21, sir. 18 to 21.
How much?
18 months.
No. So patient has already got a first-line EGFR TKI. Now has progressed on a first-line EGFR TKI. Now we get a biopsy done, and it is negative for T790M. So what is the PFS now? Okay, so the PFS, if it is positive, it's around 8 to 10 months as per the AURA3 trial. But if the T790M negative, the PFS is not more than 2 to 3 months. So that is something which I wanted to emphasize over there. A lot of time we see people that they have given a first line erlotinib or a afatinib, and then on PD they just give osimertinib. So if you are not T790M positive after the first line, the PFS is not very high. That's what. Fantastic. Next one, please, Sabeena.
So, on patient newly diagnosed metastatic NSCLC, EGFR exon del 19 positive, he was started on osimertinib, documented PD after 13 months of the start of treatment. What is the next step in the management? I think it will be. And NGS was done on the site of progression, MET amplification was noted. How do you proceed? Patient has progressed on osimertinib and a resistance mechanism of MET amplification has been found. So how do you proceed?
We can go for MET inhibitors, sir, like capmatinib or tepometinib. Actually, it doesn't have any seen this type of case, sir. So.
Okay. So what you are saying is right, Dr. Chakradhar. I mean, you can give, but will you continue with osimertinib or will you give only MET amplification capmatinib?
We'll continue with osimertinib.
Okay, so you want to go ahead and give osimertinib plus capmatinib, which is absolutely right. There are two trials which have shown that. One is the Insight 2 trial, which was for tepotinib, and then there is a Savannah trial for capmatinib, for salvoletinib, which is basically showing that yes, you can continue with that. So if you give osimertinib and capmatinib or tepotinib together, what could be the side effect and the PFS that you will get? Okay, so you will have the side effects of MET amplification, which is normally there. So you can have the pedal edema, the weight gain, the increased creatinine. One thing which I wanted to ask you was, so let's say you have started the patient on capmatinib. How will you follow this patient? What are the tests that you will like to do?
Initially, serum creatinine we will check for, sir.
Correct. So serum creatinine has increased from 1.0 to 1.6. What will you do?
We hold for the drug. We'll hold for 1 or 2 weeks and we'll repeat, sir. If it is come down, we'll continue the step.
Fantastic. So what could be the, so is the capmatinib causing an is AKI or ATN, or is it something else which causes increased creatinine when you give capmatinib? Okay.
ATN, sir. Acute tubular.
Okay. So here again, I would like to disagree with you. The reason for increased creatinine is a pseudo reason because capmatinib inhibits the MAGE transporters, which is there. So the increase in creatinine, which is there, is actually a pseudo increase in creatinine, and you just need to be careful. You can consult a nephrologist, do all the dietary modification, but it's not really an ATN or AKI which causes over there. The reason for capmatinib induced TKI is inhibition of the MAGE transporter, which is there. Okay, fantastic. Next one, Sabeena.
This you already asked, sir.
Okay, fantastic.
So patient with EGFR del 19 positive started on amivantamab and lazertinib. So what all consults would you do before starting the drug, and how do you pre-medicate the patient? And what is the most significant toxicity when you combine amivantamab with lazertinib?
We'll check for the venous thromboembolism, sir, before starting amivantamab plus lazertinib, sir. And we should pre-medicate for the transfusion reactions with hydrocodone and evil, because I doesn't have any. We have never seen the treated with this.
Okay. No.
Fantastic. I think I would totally agree with you, Dr. Chakradhar. Very nice answer. Amivantamab should ideally be given the first dose. There is an incidence of a hypersensitive reaction which can occur. So it is always better to give it inpatient, preferably in a ICU. Otherwise also, but let the resident doctor be nearby that. And always look out for DVT. Even if the patient does not have DVT, the patient, when you're giving AMI and LAS together, should be given DOACs as a prophylactic measure. It's the combination which is causing an issue. So very good. Sabeena, can go ahead.
Okay. A case of metastatic NSCLC ALK positive started on crizotinib. She came with a total bilirubin of 2.5, AST more than 8 times. How do you proceed?
So, alectinib, we all feel is a very nice, cute drug. You give it for 4 tablets morning, 4 in the evening, and patient will be absolutely okay. But you should be very, very careful. Please monitor the LFTs once in 2 weeks in the first 2 months, and then monthly after that. So let's say how much it is, how do you, there is a page for alectinib induced toxicity. So Dr. Chakradhar, you would want to take this?
Hepatic all inhibitors are hepatic elimination. So if the patient has total bilirubin of 2.5, we'll start with lower dose.
Okay. So basically, if the bilirubin is more than both bilirubin, if the total bilirubin goes to more than 2 times the upper limit of normal, and the SGOT-PD goes to more than 3 times the normal, it's an and, it's not or, then you have to stop the drug and then get reduced. So there is a very nice healthcare professional page for ILT TKIs management, alectinib. Just because it's an oral drug, don't think that nothing will happen. That's one message which I wanted to give it to everyone. Every drug is different. Please follow the protocol of that particular drug and then see. Also, if a patient has got myalgias, any specific investigation you will do with this, Dr. Chakradhar?
Viral markers with CV.
Viral markers, anything else?
CPK
You should always check for CPK levels. So that is also something which can happen with the alectinib usage. So that is also something which you should use. Fair enough. Next one, Sabeena.
So a newly diagnosed patient, ALK positive, started on lorlatinib. How would you counsel the patient before starting the patient on lorlatinib?
We'll counsel the patient attendance to look for any outbreak of anger, sir. Or a patient is having any hallucinations or talking irrespectively, look for visual or auditory hallucinations or angry impulse control output. We'll ask them to look for the patients. And for the initially any weight gain or edema is developing, we'll counsel the patients.
You can take this, Sabeena. I'm answering one question here.
Okay. So basically, you have to monitor for the weight gain and any cognitive changes, cognitive behavioral changes the patient is having, and also you have to tell them for the cholesterol things. So at the baseline, we will check, and then we have to tell the patient to frequently come and visits, and we have to frequently check the cholesterol as well as the triglyceride levels, and the patient has to be told about pedal edema. Mainly cognitive side effects, you have to counsel the patient very well so as the patient does not stop the drug because of the side effects. So anything that suspicious, you have to even tell the attendants also that this all this can happen, so they will also be well aware that this is because of the drug and not any other thing, and they can bring the patient well in advance to you before it increases to grade 3 or grade 4.
So what happens, Dr. Chakradhar, is there are certain side effects which are common in the first 3 months. There are certain side effects of lorlatinib which happen after the first 3 months. So the hypercholesterolemia, the neurological side effects, the hyperglycemia, and the deranged lipid profile, they will happen all in the first 3 months. The incidence peaks in the first 3 months. The pedal edema, the weight gain, and the neuropathy. This happens after that. The timelines of development of lorlatinib are very, very important. So the hypercholesterolemia, triglyceridemia, anger issues, liver dysfunction will occur in the first 12 weeks, and the pedal edema, the weight gain, the neuropathy will happen after that. That's a very easy way to remember that actually. Next one, Sabeena.
I think this one has already been discussed. So, cholesterol. Okay. Around 40% patients will develop neurotoxicity with lorlatinib. And what type of neurotoxicity that you see, I think this has also been discussed: mood disturbances, cognitive function changes, speech disturbances that you already told. So for grade 1, we continue with the same dose. Grade 2 or 3, we withhold till the grade becomes 0 or 1, and then we restart at a reduced dose. And for grade 4, although in the guidelines it is mentioned we permanently discontinue, but we have to see on a case-to-case basis. If the patient is having a good response, we might as well continue with a lower dose. So this also has been discussed. Alectinib on presented with mild muscle cramps. You already answered that you have to see for the serum creatine kinase levels. Okay. So this one, sir.
Which one?
Drug-induced pneumonitis. So a patient started with the with the HER2 targeted agent, that is TDXT. After the third dose, day 10 of the third dose, she presented with a dry cough, new onset dry cough.
We can't see the slide now.
You can't see the slide?
Yeah, it is not moving. Yeah, now it is. We can see it. We can see it now.
Okay, so patient was started on TDXT. After the third dose of TDXT, day 10, she presented with the new onset dry cough, and saturation was 95%. So,
Usually industrial pneumonitis, ma'am.
so it was only a dry
Actually,
cough.
we should start with the methylprednisolone of 1 to 2 grams per kg per day, madam, for 3 doses, followed by a tapering of the oral. We'll change to oral steroid and we'll should tap it, ma'am.
Okay.
If the
Okay, very good. So before that, we need to investigate also, no?
yes, ma'am.
Yeah. So we will do an HRCT. So 6-minute walk test already showed that the saturation is dropping to 89%. So how do you manage? So basically, initially you investigate and you also rule out the infective causes also, and then you start. When you don't find any other cause, if it is very severe, then you can straight away start with steroids also. If you're very sure that it is a drug-induced pneumonitis.
So here I like to stop. I like to ask Dr. Chakradhar, how do you do this 6-minute walk test?
We ask the patient to walk in the corridor, sir. With
Correct.
the patient support, someone should be around him, and we ask them to walk through the floor.
Walk fast, walk slow,
Walk slow. Walk slow.
slow. Or walk normal.
Actually, normal walks.
Okay. Okay, then
we'll check after 6 minutes of walk test. We'll check for the saturation levels, sir.
And what is more significant?
Patient developing tachypnea is more significant.
Patient developing either a symptomatically tachypnea or a tachycardia. So let us say patient saturation is only 96% and then comes down to 93%, but the tachycardia is more. So that also is a sign that there is something going on with them. So this is something which I would like to, tell you or ask you more. So let's say this patient had a SpO2, which is 95%, it dropped down to 91%. Tachycardia was there, 130. You will do an HRCT. HRCT will take time. Then what will you do? You will start with solumetrol, you said. Will you cover the patient with the antibiotic also or not?
Yes, sir. We'll cover it antibiotic also.
You will cover with antibiotic. HRCT shows bilateral new ground glass opacity seen. Then what will you do? So the HRCT report says bilateral fluffy ground glass opacity seen. Fantastic. You have started this. Then what will you do?
We'll continue the steroid and
Correct. And
we'll start on viral antivirals also.
okay, and then your infection people will come and ask you that why did you start that? Okay. So ideally, you are right. You should send for all the, as Dr. Sabeena said, send for all the the blood test, CBC, LFT, KFT, do a procal also. Ideally, before labeling anybody with a drug-induced pneumonitis, you should do a bronchoscopy if possible. Do a bronchoscopy with lavage and send all the panels for KOH, PCP, galactomannan, normal Grams stain. PCP is very, very important, and a biofiber panel if you can in your setup. If the patient is sick or if your setup it is not allowing, you may not send, but you should always keep your things open. So what are the levels, Dr. Chakradhar, of CTCE version grade 1, grade 2, grade 3? How do you say it is significant? We all say, the standard rule is grade 1, grade 2, give some oral things, grade 3, admit, grade 4, don't re-challenge. What is grade 1, grade 2, grade 3, grade 4?
For shortness of breath, sir.
For breathlessness, dyspnea, or drug-induced pneumonitis. Okay, so grade 1 is basically if you find out only radiological abnormalities. Grade 2 is patient is symptomatic. Grade 3 is patient is symptomatic and you want to requires admission, and grade 4 is much more support is required. Grade 1, grade 2, you manage only with oral steroids, stop the drug till the time it resumes to grade 1. Grade 3 is you admit the patients and for all those things, do not start it when till the time it resolves to grade 2 or lesser. So let us say the patient starts improving. You have given control 1 milligram per kg body weight. For how long will you give, and how will you taper it off? 7 days, 10 days, 20 days, 45 days. What will happen?
Sir, we'll for methylprednisolone we'll give for 3 days and we'll change to oral steroids, sir. But we look for up to 12 weeks, sir.
Fantastic. Very, very nice. You have to do a gradual taper of steroids. That is the most important thing. And then also do a PFT with DLCO and maybe an HRCT to make sure that the toxicities have come down to less than grade 1, and then only restart. Because somebody who has got a drug-induced pneumonitis has a 30% chance of getting another episode of drug-induced pneumonitis on rechallenging. So you should always do that again, and very, very important with all these new ADCs and IO drugs that you should know how to manage a drug-induced pneumonitis. Very good. Go ahead, Sabeena.
So what is the rationale for combining the dabrafenib with trametinib? So dabrafenib is a BRAF inhibitor and trametinib is a MEK inhibitor.
We should, if the only BRAF inhibitor is a inhibitor, the MEK activation will be done. Again, it will be proliferation will be. So for both, if it's a BRAF inhibitor, we should compulsory add a MEK inhibitor, madam. For the stoppage of the other pathway of MEK pathway.
Sir?
So you said, right, what is one side effect if you give it dabrafenib, which increases if you don't give trametinib? One side effect. So are you friends with dermatologists?
Yes.
Then become friends with dermatologists. If you have dabrafenib, what is the incidence of secondary cutaneous cancers? Find that out today, okay? And what is the incidence if you combine with dabrafenib and trametinib, okay? Fantastic. Repotrectinib, entrectinib, I think we have said this. Next one, Sabeena.
We went it. You can take the questions of the chat. We are done with the questions, sir.
Okay, we are done with the questions. There are no questions in the chat. Yes, please. Okay. There are no questions in the chat. We are done with the MCQs that we have. Uh, okay. So any other question or something, or I'll hand it back to the organizers. It was very nice, Dr. Chakradhar. You have answered very, very well. I mean, at your, I don't know whether you're second year or third year, but I would have been half as empty as what you would have been, what you have been. Fantastic. Very good.
Thank you, sir.
Any questions that we have, we can actually put it into the panel and into the chat box, and then we can discuss that.
So currently, we don't have any questions, sir. I just asked students, are there any questions? You can ask. Ullas sir is here. Please post in the chat box.
Okay, so there are two questions. If there are two, I think we are getting a lot of questions about two mutations in NGS. I think very, very important is, first of all, please realize that two mutation in NGS is not a very common thing to find out in de novo. Now, there was a question regarding EGFR and MET. So in EGFR and MET, you have around less than 5% chances both of them can come together. Normally, these are mutually exclusive agents. So if you have an EGFR and MET amplification at beginning, ideally it will make sense to use a amivantamab plus lazertinib kind of a regimen, which has shown you can actually use OC plus savolitinib or capmatinib also, but that's not an FDA approved regimen. So maybe we can use AMI and we can always use AMI and lazertinib, which is not available in India. Then you can use a FLAURA2 kind of a regimen. Regarding EGFR ALK, both together, EGFR ROS both together, I think it is better to confirm this by a single gene testing also. So let us say you have in your NGS report where you have, let's see, so you should always go back and talk to your molecular pathologist also. That listen, this is not something very common, and this is very important to have a healthy communication with your molecular oncologist. I'm Dr. Mashmi is there in this thing as well. Take this patient to your molecular tumor board. Have an orthogonal testing. Orthogonal testing means if you have, let's say, an ALK there, confirm it with FISH, confirm it by IHC to make sure that these two both exist coexistently. Sometimes what happens is ROS is detected by IHC and negative by FISH, or sometimes it is always good to confirm by another method to find out that there is no, that just to make sure that this both is there. How do you manage if both of them are there? See, you can always combine these two agents together. You will not get case series, you will get some case reports. Like we have a paper of somebody we are right now giving osimertinib and dabrafenib trametinib together. We have given osimertinib plus alectinib together, but you have to look at the toxicity. So what do we normally do when we give osimertinib and dabrafenib trametinib together? We start with the low dosages of dabrafenib and trametinib. We start with a low dose and then slowly increase to a higher dose. Look at the concurrent, like both dabrafenib, trametinib, and OC can have an increased QTC. So we ask the patient to do a QTC every 2 weeks. If you have EGFR and ALK, we have given OC alectinib together. So look out for toxicities. You can give it sequentially also. Look at the VAF of what is there. Let's say the EGFR VAF is 60% and the ALK is, by and large, the fusion read is not very great. So whether you ask your molecular pathologist, it's a subclonal mutation which is now coming up, which will change across over there. So it is very important to read the NGS report properly and then act on that. Just don't have a knee-jerk reaction on that. That's a very, very important point actually. Okay, so which database to find ongoing trials? So the trials, this thing is CTRI. There is a website by CTRI which basically tells you all the clinical trials which is going on. Slightly difficult to find out from there. So we have there's an NGO organization called as Lung Connect. They have worked very hard on that. It's an NGO. They are working with Tata's mainly. Dr. Kumar se ke saath mein they work. They have on their website about all the trials which is going on. Otherwise, very easily, there's a WhatsApp group which is there, clinical trials, medical oncology, or this thing. You can put their questions. Normally, one of us will answer. And that is why it is always good to have a young medical oncology group. Most of your colleagues will be working here and there, and they can ask people. But it's very nice and very nice to get these questions, that people are now getting used to and thinking about trials. So that is Very nice. To me, clinical trials is very, very important. But again, please note that you should have the right patient for clinical trial. A PS in a clinical trial patient have to be, the performance status of the patient has to be very, very important, and the education qualification also, patient should understand what they are going to get into. So there's some pros of clinical trials, cons of clinical trial. They have to come to the institute very regularly. They have to be on time. Compliance has to be very, very important. The best thing is there are people who will get latest drugs, and I think clinical trials is good for both the oncologist as well as the patients. That's the best. And NCCN actually used to say, the best way to treat a cancer patient is by the virtue of a clinical trial, and I totally agree with that. There's another question which says, can we change with capmatinib if progression with no? So let us say what they're asking is that if you have a person who has got MET exon 14 splicing mutation, and you have got a patient with tepotinib. So please understand, tepotinib and capmatinib are the same group. It doesn't really make a difference. So if you have a patient who has progressed on tepotinib and capmatinib, again, at progression, there are three ways in which progression occurs. One, you can have an on-target mechanism, that is with the MET only some new mutation will come. You can have an off-target, that is with MET and ALK or ROS or EGFR can come. Third is a phenotypic change. It can convert to small cell. So for all of you who are answering, whenever they say about drug resistance, three ways: on-target, off-target, phenotypic transformation. There are next generation targets available, or let's say there are MET mutations which are, I think, G12D or something which comes over there. You can try with cabozantinib or multi-kinase tech inhibitors. In case of MET exon 14, I'll be absolutely okay in doing a biopsy, sending for in an NGS. If something comes out of this, very good. If nothing comes out of it, put immunotherapy. Because immunotherapy can, plus minus chemotherapy, can work in MET exon 14 skipping mutations also. The response rates are reasonably okay with that. So I think that answers this question by Dr. Mahapatra. There's a question by Ashok which says metastatic adenocarcinoma with exon 19 single site PD in brain after 15 months. Whole brain RT. What will be next? Okay, fantastic. So a very nice question, Ashok. What you have asked is that EGFR exon 19 deletion started on osimertinib, single site PD in brain. Now, very important as a medical oncologist or as an oncologist is, when you said a single site PD in brain, whether it's so it's an oligoprogression. Now, whether patient has a single a site met in the brain or multiple, every effort should be made to avoid whole brain RT in 2025. Now, if it's a single site, you can jolly well go ahead and do a surgical resection and then give RT to a post-op RT. You can give an SRS boost, or you can give a SRS only to that lesion and then continue osimertinib. Even if you want to give whole brain RT, try doing a hippocampal avoidance whole brain RT, because these people are going to live for a long time. When these people live for a long time, you can avoid the toxicities of whole brain RT. So I think we did an audit of all the whole brain RTs that we have been giving in our institute for last 10 years, and the whole brain RT, we try to avoid whole brain RT as much as possible, because if you look at this, 19.2 months was the PFS with osimertinib. People still live for 38 months. So that means there is a good amount of 1.5 years which they will live. So just to answer your question, consider this as an oligopd. Give RT, preferably SRS or an SBRT to the brain lesion. If not, hippocampal avoidance. If you have to give whole brain RT, and then you can continue with osimertinib. Next best option is, if you have to anyway change the treatment, you can give, there are a lot of options. Others do a biopsy from the oligoprogressives from the site of progression, send for MET, send for everything, and then treat along with the, you can go ahead with the Mariposa 2 regimen. You can go ahead with the, if you have MET amplification, you can go with MET amplification, all regimens, etc. with that. Or ABCP is also is an option. Okay. Third one is, once IO-induced pneumonitis grade 3 recovered, can you re-challenge lower dose? So dose doesn't make a difference. With pembrolizumab, there are two dosages you can give. You can give 2 mg per kg body weight. You can give a 200 milligram. Dose does not make a difference with pembrolizumab. It is not that, if you give 200 mg and then you give 100 mg, it's not going to come down. 33% of people who have a drug-induced pneumonitis will get either some other amount of autoimmune, whether it is thyroiditis or hypophysitis or something else, if you rechallenge them. Dose here does not make a difference. Whether it is 200 or 100, it doesn't really make a difference. Approach in unaffordable patients. Do you put on first generation TKI and side effect management? I am not so sure what first generation TKIs are we talking about. Okay, so you have to weigh the pros and cons of it. The first generation TKIs now cost around 5,000-6,000 rupees. Second generation TKIs of afatinib will cost around 8,000 rupees. The third generation TKIs will cost a costly one. So my choice would be either, a lot of time people are not willing to take chemotherapy. The moment I tell them chemotherapy, PEM, CARB, JEFT or something, people don't want to take treatment. I'm very, very happy with the second generation TKI. So what I do is I start them at a lower dose. Let's say there's a patient of PS2. I'm very happy. And if they cannot afford osimertinib or combination therapy, there are two choices: afatinib 30 mg, or you can give a PEM carb JEFT, the famous NK regimen, Naronoha Kumar regimen that I talk about. Very fond of these two people in my life. That's a very good regimen to work for. Or if the patient does not want chemotherapy, I will want to go ahead with oral afatinib 30 mg. Works very, very well. There are people in 72 years of age who didn't want chemotherapy. I've given 20 mg of afatinib. Works very, very well. Should not really be a problem. Next one is how to manage de novo low MET amplification. So again, very, very important. There's nothing called as MET amplification. You really have to know that there is nothing we don't know as what is a good MET amplification. Whether it's a copy number gain of less than 6 to 8, or more than 8 or more than 10. Typically, various trials have used various things. Very, very nice is if you have more than 8 or 10 copy number gain, it is absolutely okay. Less than 6, don't even look at it. Don't even think about adding anything else because it does not really work. If you have a MET amplification, so whenever you have MET amplification, ask your molecular pathologist to confirm it by FISH and then look at the copy number gain. It has to be more than 6 to 8. Then only there is a benefit in adding a TKI to this, because please try to understand all these drugs, both these drugs are A, costly, and B, toxic. So to be very, very sure that you are dealing with that, I think MET amplification, ask your, the single most important thing is do a FISH test. If the MET amplification level is more than 6 to 8, then only you go ahead with adding EGFR and TKI into this. Okay. Then ये पहले पूछ लेते सारे के सारे क्वेश्चन, एंड में जरूर पूछने थे. Okay. Suppose you want to check for phenotypic changes as a mechanism of resistance, the biopsy. Okay. The biopsy should always be done ideally from the site of progression, because that is what we feel is the most common site of resistance. So let's say if you have a new liver lesion or a new cervical lymph node, so for biopsies, always remember the most least invasive, least painful, and most informative to the oncologist should be taken. So if you have a liver lesion, which is a new one, take it from there. That is, and that's not even for phenotypic transformation. It is for everyone. If you want to see the most resistant clone, so take it from the new site of the lesion that is there. Can we consider tablet osimertinib 160 mg OD with the addition of bevacizumab in such a scenario? Anybody who has given osimertinib 80 mg BD will tell you that please don't go ahead and give osimertinib 80 mg BD, because what happens is that OC80 BD has a lot of hepatotoxicity and BP raise. OC80 BD plus bevacizumab, be friends with cardiologists. You will definitely get hypertension. Patient will get hypertension and you will get double hypertension. So we use osimertinib 80 mg BD, but we use it in leptomeningeal mets. Let's say somebody, the Bloom trial regimen. Basically, when somebody has got a leptomeningeal mets on a 80 mg OC and patient does not want anything, I have given 160 mg. Financial toxicity is a concern, cardiotoxicity is a concern, hepatotoxicity is a concern. But if somebody can tolerate it, only osimertinib 160 mg works for a leptomeningeal mets. That is what we will do over here. Okay. Why is FISH approved method of ALK testing and not IHC? I will disagree with the question, Vamshi. IHC is the preferred method. In the exam, Please always say in the exam, forget the exam. You can still get away with the exam. In the clinic, ALK by IHC is the preferred approved method of testing. You do not need to confirm it by FISH. So ALK testing by D5F3, Ventana platform, just say that and you will get definitely pass. You don't have to confirm it by FISH at all. Okay. So one patient who is ROS positive on crizotinib, who have oligoprogression in the brain. So again, if you're on crizotinib, you will always have oligoprogression. 40% people will develop brain mets. Once they have this progression, give SRS or SBRT to that. Will change to NTRK or LORLA, but any liquid biopsy. So please remember, I will only do a liquid or a tissue biopsy when I want to change the treatment. Also, liquid biopsy, you need to isolate the DNA. Now, when there is an oligoprogression, the tumor will not even shed that much amount of ctDNA for you to analyze something. So liquid biopsy is cute, but you need to know that you need to have. So if you want to celebrate Valentine's Day, you should have a Valentine or a wife or a husband. You can't be single and be celebrating and say कि मैंने Valentine's Day पे ये किया, right? So the tumor need to have that amount of tumor needs to shed ctDNA. If you have only oligoprogression in the brain, you will not shed the ctDNA. Then what is your liquid biopsy pick? So I will not like to do a liquid biopsy in ctDNA. If there is a oligoprogression in the brain, give SRS, SBRT, continue with crizotinib, do a next investigation in 2 months' time, and then we will see. I thought I was the examiner. It was not my exam. Okay, EGFR exon 19 deletion, PS1 patient with leptomeningeal disease. Slightly difficult to imagine that patient with leptomeningeal mets will have a PS1, but just to answer your question, if somebody has a brain mets or a leptomeningeal mets, the only and the best option is start osimertinib at 80 mg per day. Do not start at 160 mg, start at 80 mg per day, reassess in 6 weeks time. There is little or no role. In fact, if the patient is PS1, you can actually add chemotherapy, because in the FLORA2 trial, the best results were obtained in patients who had brain mets and had, they didn't obviously include leptomeningeal mets. But if the patient is PS1, can tolerate, give OC plus minus PEMCA. FLORA2 regimen will be fantastic for this. Otherwise, only FLORA is absolutely great. Okay. De novo presentation on ALK and BRAF mutation. Please check your lab. Please do a liquid biopsy. Please change your lab. Get one more tissue. Get it tested again. I think it will be difficult to combine. Look at which has got more VAF. So ALK is a fusion, BRAF is a mutation. Do a orthogonal testing and you will get an answer by and large. I would probably give, crizotinib or lorlatinib before then BRAF mutation, because I believe that ALK is a more aggressive disease. It will go to brain more. I will treat the ALK first, maybe add daratumumab later, but rare scenarios, yeah, very rare scenarios. Okay. If you want to save the cost, can we try to give low dose Nivo 40 mg? I knew this will come somewhere. Do you have generic nivolumab which is going to get available? See, the point is, medical legally, you need to be safe. Tomorrow, if somebody comes and asks you, where is the data for 40 mg nivolumab in a clinical trial, please go ahead and do it. Outside the clinical trial, I would be very skeptical. In the exam, don't even think about saying it. Please, you will stick to standard. Tell that you will want to approach the patient and put them onto a clinical trial. And you can always send it across to us. We will always have a clinical trial. Akhil will have, me will have, CMC Velour will have clinical trials. I think a lot of people will have clinical trials. Just put them across somewhere over there.
Sir, I'm so sorry to interrupt. I think this one question will mail you, sir. Only the last one is left.
I know everybody wants to sleep. So benefit of immunotherapy in KRAS 12D, yes, please go ahead and give it. There is no target therapy. Go ahead and give according to the PDL1 status. That is what we will do. Okay.
Yeah. Thank you so much, sir, for throwing such brilliant questions. I think it's
brilliant questions. Questions are brilliant. I am not sure the answers were.
No, the answers were really amazing. And we had such in-depth discussion, including the real-world clinical dilemmas. And as you were keeping Chakradhar on his toes, hope all the students have jotted down all the questions you asked. It was a great presentation by Dr. Sabeena. Thank you, sir.
Nice again.
Thank you, Ullas, sir. Thank you, Dr. Sabeena. I would
thank you very much.
Thank you.
And please don't miss the next one by my favorite Senthil. So I mean, this is something which I will log in to listen to him.
Yes, sir. We're all waiting for the next session too. So the
Yep.
next session is on 23rd. We'll be discussing on the breast malignancy, the common drug used. Our examiner would be Dr. Sendil Rajappa. Moderator is Dr. Vinit Govind. And the subject mentor would be Dr. Vidit Kapoor. And our speaker is Dr. Barinini Ghosh. Thank you, Ullas sir, again for an exhaustive session. I thank everyone. I thank Amrita E-Gurukul for conducting these sessions and moderating the sessions very well. Thank you all. I would like to conclude this session for the day. Thank you.